Good afternoon, everyone. I'm Dr. John Shrigley, the expert lead for the Canadian Against Cancer.
And on behalf of Cancer Care Ontario, the Canadian Partnership Against Cancer, and the Canadian Association of Pathologists, I would like to welcome you to today's CAP checklist education session on endometrium, and also covering a little bit about ovary, peritoneum, and fallopian tubes. Before we start our speaker and we get underway formally, I'd like to take care of a few housekeeping items. The session is being recorded and will be made available to all participants via email links once the reading becomes available. Both presentation and recording presentation are eligible for CME credits. The information for obtaining credits was provided in the notice of the session previously distributed. Please note CME certificates for each of these CAP checklist education sessions will only be issued for 1 month from the presentation date. Please refer to the session notice for the exact deadline date. Please note that everyone's line has been automatically muted for today's presentation. A large number of participants and may have difficulty troubleshooting any WebEx issues as part of this call. If you're having difficulties, please use the WebEx line at 1-866-229-3239. We encourage you to submit questions at any time during the presentation using the chat feature. Documentation previously distributed provides instructions for using the WebEx chat window. During the question and answer portion of the presentation, in order to avoid collisions, a CCO staff member will pose the submitted questions on your behalf as long as time permits, in the order in which they appear. In the window, please include the following information: your institution's name, of the individual posing the question, and then finally your question. It's a pleasure to introduce Dr. Blake Gilks. Blake is a professor in the Department of Pathology and Lab Medicine at the University of British Columbia in Vancouver, BC, and does his clinical work in the Division of Anatomical Pathology at Vancouver General Hospital, the largest gynae-oncology program in the province of British Columbia. Director in the Division of Anatomic Pathology, and currently also serves as the interim medical director of laboratories for Vancouver Coastal Health Region. Blake graduated from Dalhousie University in 1982 and did a residency in anatomical pathology at the University of British Columbia, followed fellowships in gynecologic pathology and molecular pathology at the Mass General and Fox Chase Cancer Centers, respectively. Dr. Gilks leads a research program focused on gynecologic cancers and is co-founder of the Genetics Pathology Evaluation Center, a laboratory that uses tissue microarrays of human tumor samples for cancer research, and also OVCRE, a multidisciplinary team studying ovarian cancer. Also the co-founder and co-director of the Canadian Immunohistochemistry Quality Control Program, provides proficiency testing for Canadian diagnostic immunohistochemistry laboratories. I'd like to now introduce Dr. Blake Gilks to give today's talk. Note earlier that Blake said that it was spring and the cherry blossoms were blooming in Vancouver. That's certainly not the case in Ontario. Blake?
John, no, we always like to talk about the weather this time of year when we call back east to family. It has been raining for 3 months, so there's ups and downs. Today we're going to talk about endometrial cancer checklist, and we're going to go on and talk about the checklist that's going to be forthcoming from College of American Pathologists for ovary, tube, and peritoneum. Unlike the geology folk, we're not that coordinated, so we have WHO, then we have ICCR, and the last will be CAP, and that will align all of the tube over peritoneal information. But the checklist as it currently exists, I didn't think it was worth spending a lot of time on, just being aware of what's going to be coming in the future. So without further ado, I have no financial relationships to disclose. Talk about the importance of tumor site in the endometrium and a change request made on behalf of the CPAC endometrial expert committee to the College of American Pathologists to change the checklist. There's a couple of those that I'll mention, but relatively few. So the endometrial cancer checklist will be updated, but no big changes to be expected there. About stromal invasion versus mucosal implant, history assignment, how to diagnose mixed carcinomas. We'll talk about assessment of depth of invasion, diagnosing mismatch repair protein expression loss in endometrial cancers, and a slide at the end to talk about really exciting developments in genomics of endometrial carcinoma that within the next 2 or 3 years, I would guess, will flow through and we'll see their application in practice. Specimen types, and here is all relatively straightforward. Procedure and specimen become important when cancer is not suspected and you get endometrial cancer and you have a supracervical hysterectomy, or you have one where there's a laparoscopic hysterectomy where they've used a manipulator which can displace into the fallopian tube or even into vessels, or finally a morcellated specimen. We see relatively few of these cases in a gynae cancer center, so I don't know how common that is, but it does impact the ability to do cases accurately when you don't receive an intact hysterectomy specimen. And integrity on the checklist, you're offered these choices. We made a request to cap, add, and error. For example, if you receive the cervix separate from the corpus, there's not really an option that encompasses that. That would be an uncommon event, of course. Mostly it's a hysterectomy without parametrial tissue for endometrial cancer, and it will be received intact, but not always. So that was a request. We haven't heard back about our request there with the committee. I guess I should tell you a little bit about how the CAP committees work. I've been on it for some years now, and it's always a surprise to see what's on the website as a committee member, so that quite involved in 2007 in the current checklist, but the subsequent revisions did not go back to the committee, and there's some amusing parts. They've now tried 3 times to get the mismatch repair designations correct and still have not quite managed. There's an MLH2 still listed in the checklist. What can you do? But the committee has reconvened this year. It's a larger committee, and it will probably go a bit more slowly because they're looking at biomarkers this time around with the ACC upcoming. So not just histopathology on routine H&E, but try and consider the biomarker part on the histopathology part of the checklist committee. So changes in the works, but relatively minor ones, I think. Here's another one of the changes we've made. Currently, you're asked anterior, posterior, other. We thought that was really relevant, so we asked that it be corpus, lower uterine segment, both or other. And the importance of lower uterine segment, its strong association with Lynch syndrome. I think it was worth designating that. Here's an example of a where there's a uterine segment involved. When further down the canal, it raises the possibility of an endocervical adenocarcinoma related to HPV, but most of these are turn out to be of endometrial type by immunophenotype. There is association with Lynch syndrome and also higher risk of lymphatic invasion compared to the tumors that arise further up. So made that request. I expect that it will be incorporated into the upcoming check. So a new option in terms of designating. It's admittedly a bit fuzzy what constitutes constitutes lower uterine segment. There's not an anatomical landmark either macroscopically or microscopically, so it's an impression. It's relatively uncommon to open up a uterus and see something like this where you say, wow, that's not a usual endometrial cancer. It's further down the cervix. Tumor size, relatively straightforward. My practice is just to give one mention. In the International Consortium on Cancer Reporting, they have reviewed evidence on tumor size, and there's evidence from the Mayo Clinic that less than 2 centimeter as opposed to more than 2 centimeter based on greatest dimension macroscopic assessment, see differences in outcome, and in very aggressive surgical center, less than 2 centimeters, they confined to the inner half, they would not do no section because the risk is so extremely small. So that information is used in some centimeters. I don't know of any center that would use the second and third dimensions. And I think it helps to know that there's a 2 centimeter cutoff. So if you can't tell whether a tumor is 3.5 or 4.5 centimeters, it doesn't really matter. Just give it your best shot at that point. But for the smaller tumors, an accurate assessment is important. It's not part of the treatment guidelines in our province, but it certainly is in some centers. Histotype is in transition. We submitted on behalf of CPAC Endometrial Committee asking that this be brought in line with the 2014 WHO Blue Book. The ICR says it even further. They have endometrioid, mucinous, serous, clear cell, undifferentiated or dedifferentiated mixed carcinosarcoma. So they get rid of things like transitional, squamous, don't block the endometrioid variants. And I can see the rationale for doing that. The subtypes, as we'll come back to at the end, are becoming important. The reasonability of subtype diagnosis is only moderate. The kappa statistics associated with inter-observer variation of serous versus high-grade endometrioid is disappointingly low compared to ovary, where histotype diagnosis is robust and highly reproducible. So this long list, and it probably needs to be trimmed, and that is one thing that we can expect. At the very least, it will be aligned with the WHO classification moving forward. And that shouldn't, do you capture every rare subtype? Probably not necessary to get tumors that you expect to see once in your career as a surgical pathologist, and the checklist with those types of tumors. But certainly we'll have endometrioid, serous, clear cell, mucinous, thought to be just a variant of endometrioid. Mucinous differentiation is common in endometrioid. Additional, not really a standalone entity, same with an ovary. And you transitional-like differentiation. You also see it in endometrioid, lower grade tumors where squamous differentiation is solid, more spindled. The dedifferentiated carcinomas, we'll just talk briefly about further on. Chang-Han Lee and Edmonton's leading the chart in this. It was described by Dr. Silva, very poorly differentiated tumor associated with a very low-grade endometrioid cancer, and now appreciate that it's actually molecularly quite distinct with Y P53 and abnormal mismatch repair in 70% of cases. Still know the natural history. It's early in the days of defining its natural history, but it seems to be something that we can reproducibly diagnose. Not to be overdiagnosed. We don't want to call just a high-grade endometrioid cancer or solid serous cancer undifferentiated. We want something that truly shows no signs of differentiation. Endometrioid variants are important for us as pathologists, not so important for our clinical colleagues. So glandular differentiation, not to be mistaken for serous. Here we have small non-villous papillae with detached but cells with laid nuclear fissures. Retain the possibility of serous, but the wrong cytological findings. Differentiation, very common, and you feel obliged to comment on it in your diagnostic report as a personal preference issue. A tumor mucinous carcinoma of the endometrium is very uncommon. But mucinous differentiation is noted here, up to 40% of cases. Brings in an inflammatory infiltrate, which also extends into the tissue and associated with the low-grade end. So mucinous differentiation with endometrioid carcinomas within the low grade, that is grade 1 or 2 endometrioid tumors of no clinical significance, that association with low grade notwithstanding. Carcinoma, you can see the resemblance to carcinoma of endometrioid type with small non-villous papillae, but much higher nuclear grade. Mytic index you generally don't have to rely on, but low-grade endometrioid cancers typically less than 1 per high power field, whereas the serous carcinoma is readily apparent mitotic activity. The high-grade cells tufting off. The immune stains for p53, if you're dealing with one of those tumors that Rosaslo has described so well as being of indeterminate type, is it low-grade endometrioid or serous? That's really an important distinction because that weighs into treatment decisions, and p53 does have merit and has been demonstrated to correlate with the phenotype. So abnormal p53 staining. Just to work the last CIQC run where we looked at p53, the interpretation of p53 immunostaining in this text, if it's completely absent or it's strong nuclear staining in every nucleus, that's abnormal. Anything less is wild type. In the run 42 CIQC, the p3 interpretations were all over the possibly related to the small sample. So the question with mutational status not so good, but we rescored them all and then it was better. You do have to have fairly intense p53 staining to be able to detect the nothing opposed to the low level expression you can see in some of endometrioid cancers. Having done that, it should be possible to use p53 in this context to help distinguish between carcinoma, papillae, glandular architecture versus an ambiguous tumor where the differential would be a lower grade endometrioid cancer. So on clear cell carcinoma. These are quite uncommon in our practice. You have serous carcinomas with some clear cell features the same way you do in the ovary, but clear cell carcinoma, not so common. Again, Hanley, nice work showing the absence of hormone receptors and normal pattern P53, which distinguishes it on the one hand from endometrioid, the other hand from usual serous carcinomas. Hard to get a handle on the natural history because it's so uncommon, but it appears that if you exclude serous cancers with some clear cell differentiation, it may be a better prognosis. Still considered high grade, though. Sarcoma has now moved into the carcinoma category, fully managed, treated as a high-grade carcinoma. The evidence in support of heterologous differentiation, which we see here, slightly worse prognostic factor. I've often wondered if that's because the ones that have heterologous differentiation really are carcinosarcomas, and that some of the ones called carcinoma with homologous differentiation are just spindle cell elements that perhaps are diagnosed as carcinosarcoma. Nonetheless, we do distinction between homologous and heterologous elements. It's controversial whether typing the epithelial component is any value. I know in some centers it's done routine. It has not been a routine here, but it is part of the checklist and is coming. But it's case I've had this feeling if I see high-grade carcinoma in a curette and I'm having trouble typing it, make a special look for the malignant stroma and then call it carcinosarcoma, you're off the hook. It's often exactly like the epithelium we see here. It's actually rather difficult to place in terms of whether it's endometrioid or serous. It's certainly high grade, but particularly distinctive as one or the other. Most end up getting called serous, I believe. Dedifferentiated, undifferentiated, shown here where you have a very low grade focus, really just atypical hyperplasia here. Then you have sheets of cells that on their own aren't even overtly epithelial. They can look like myeloma. For example, in the past, I think a lot of these were called carcinosarcoma. They weakly or don't express epithelial markers like carcinosarcoma. They're not recognizable sarcomatous elements. They truly are undifferentiated, or if you have a low-grade component, dedifferentiated. These are the ones that, in most instances, show abnormal mismatch repair protein expression. Unlike serous, where P53 abnormalities are present, very high percentage of cases, just like high-grade serous of tubal ovarian origin, you do not appear to be a P53-driven tumor. Something obviously happens between here and here, but we don't know what is, and it seems to be an outgrowth in most cases of the genetic instability associated with microsatellite instability. So we just started to get a handle on this subgroup of tumors. Probably something that we'll be able to recognize in the future with a degree of reproducibility. Mixed carcinoma, two or more distinct subtypes identified, not sort of a blurring between the two. The types are supposed to be 10% or more, but in practice we report any high-grade subtype, just assign a percentage to it. We've asked for clarification in the CAP checklist around this point. It's a little ambiguous, the handling, but I believe the recommendation will be to document any high-grade component. And mixed carcinoma, what's it really mean? We don't really know high degree of variability in diagnosis of mixed carcinomas, but certainly you do see them with some regularity in the endometrium, sometimes strikingly so, where you get transition between the low-grade endometrioid and an abrupt transition to a high-grade serous. You may even see P53 immunohistochemistry with wild-type expression, low-grade abnormal expression, and the high-grade. Not the basis for diagnosis, it's a morphological diagnosis, but it does appear to be a progression in those cases, clonally related progressing to a higher grade tumor. In a sense, the differentiated carcinomas are a special variant of mixed carcinoma. The histological grade for metrioid or endometrioid carcinomas with mucinous differentiation. Nuclear atia bumps it up by 1, and the readability of grading not very good. So again, kappas which edge into the moderate range, no prospect of improving it, and it relates to what constitutes solid non-squamous growth, which is pretty arbitrary. So it looks good. Numbers are sort of easy to convey in writing, harder to use in practice. Grades 1 and 2, relatively interchangeable once you get to a hysterectomy specimen. So if you have a hysterectomy specimen, grade 1 or grade 2, stage 1A, no one anywhere is going to offer adjuvant treatment, especially the no lymphovascular invasion. So 1A, grade 1 or 2, and then grades different. It increases risk. And proposals to combine grade 1 and 2, they've not really caught on. When you look at curettings, tumors called grade 1 are less likely to be deeply immunoinvasive or operated on hysterectomy specimen than tumors that are called grade 2. I always thought that just reflects amount of tumor. If you have a little bit of tumor in the direct or in the biopsy, you call it grade 1. If there's more, it tends to somehow morph into a grade 2. You see that 5% solid threshold being reached. How do you correct for that? So it's used sometimes in deciding who gets lymph node dissection based on the biopsy, but once you get to the hysterectomy, places would not use that distinction, which is reassuring. That's not a distinction that drives therapeutic decisions. Grade 1, also familiar, low power look, too much endometrium in a postmenopausal lady, differentiated throughout with glandular differentiation. Showing an easy one. If this squamous differentiation becomes more challenging to assign grade, here's a grade 2, where we have solid elements, but mostly gland forming throughout. And the solid parts do not look squamous. And higher grade, dominantly solid endometrioid carcinoma. Solid endometrioid, grade 3 versus high grade serous, not really helps in terms of different diagnosis, except to look maybe the lower grade component that it merges with, or a more architecturally differentiated component. So solid serous may be associated with a more papillary serous component. Solid endometrioid may be associated with a conventional lower endometrioid component, but no good guidance in terms of how to separate those two. The histologic grade for all other histotypes, and it's not really helpful. So clear cell are by convention grade 3. Should build that into the checklist. Carcinosarcoma, the same. We don't diagnose low-grade carcinosarcoma. If you do, it serves its own little report. It's not list compatible. It's a one-off where you can't relate it to a bunch of similar cases. The checklists are designed to pick up the common things and allow them to be related to cases with similar indices that predict outcome and guide patient management for one-offs. Not so useful. Endometrial invasion, depth of endometrial thickness, and sometimes you can't determine the exact depth of invasion. Leiomyoma is a notable cause of that. And cutoff for treatment and staging less than 50%, greater than or equal to 50%. Occasionally you can't determine it. You might get a more slated specimen, for example. So often you can measure it, sometimes can't. Invasive, the irregular endometrial myometrial junction outlined here. Sometimes it's more pushing, but it's a pushing invasion. We change the staging system to reflect the fact that we were hopeless at distinguishing between the truly superficially myoinvasive and non-invasive. So it's easy. You look for the clues like benign glands that rest between the myometrium, indicating that this has not gone deeper than the end of the endometrium, but often it's just a guess. And both are grouped as stage 1A now under the new staging system, which is great. Removes that irreproducible variable as a staging element. Inner myelination, in this case, there's an obvious stromal action, but you can't count on that. Cases that are sort of tweens, you actually have to get the ruler out and measure invasion, thickness of myometrium. Fortunately, mostly they're either outer half, out where the large vessels are, or inner half, obviously. But occasional cases are boundary between stage 1A or 1B. There can be some variability in how those are assessed. Carcinoma involving adenomyosis is always problematic. Carcinoma with very thin myometrium, you have an exophytic tumor going into endometrial cavity. In a postmenopausal lady, the myometrium can be quite thin. And then carcinoma involving the corneal region, where it extends out into the intramural part of the fallopian tube. And then the landmarks are lost in terms of depth of invasion, inner half, outer half. So this one here, you just have to know where the sections are from. Not a suitable area for assessing depth of invasion. If possible, we do that in other sections. So adenomyosis, you have malignant glands separate from surface, but carrying with it endometrial stromal cells or benign glands. Well, that's easy if it does that. Sometimes it doesn't. Sometimes the invasion is just a small area coming off the adenomyotic focus. Measure from there. Good. How best to handle these is when you get admixtures of adenomyosis and invasive cancer. Where do you from becomes a bit arbitrary. If this, for example, there was a area of invasive cancer here, but you just measure down from the overlying endometrial myometrial junction. If you had just small focus invasion here from here, but there are enough cases where you really scratch your head and start with, but no one has guidance for us in those cases in terms of what's the most clinically meaningful way to measure those cases. So you document that it's problematic because of colonization of adenomyosis and give it your best shot. thin endometrium. So very thin, less than a centimeter. There's the thick-walled vessels that mark the outer half, but you can see this tumor is actually benign glands deep to the tumor. So even though myometrium appears thin, it's not even invading across front. Is you're getting out to the region the thick walls. You're only 8 millimeters from the serosal surface, so a very thin myometrium, but areas of invasion all along here, and the deepest one right here. And comes, of course, where do you measure from in a case like this? So you can guess the endometrial myometrial junction is and measure down from there. Involves the cervix. We now have stage 2 being based on stromal invasive cervix, not mucous involvement. This turned out in the ones I'm aware of where they looked at reproducibility, turned out to be not very reproducible, which means we need better criteria or better tools to assess cervical involvement. So, drop metastasis or implant involves the surface glands, does not invade the underlying stroma, not prognostically significant. Whereas it's in amongst the benigns, obliterating the normal fracture, superficial, 5 millimeters down, but definitely invading cervical stroma in this case. Peritoneal fluid may be sent, may not. It's not part of staging, so we're finding fewer and fewer cases where this is sent. It's atypical, reactive, suspicious for malignancy. We have to qualify what we think it is. With the use of on cell blocks, we have fewer indeterminate cases in cytology, but here you really can be stumped. You have cells with low-grade atypia. They're epithelial, not mesothelial. They could still be from endometriosis, for example. Just because they're epithelial doesn't mean that they are necessarily derived from the tumor. We'll have some cases that are not further classifiable. Definitely negative, definitely positive. Margins we usually don't comment on, but you have that option for those cases where margins closely approached. So I don't normally have parametrial tissue either, but if you do have parametrial involvement, you would comment on it. Vascular invasion is important to recognize. It's part of most risk assessment tools, and also plays into patient treatment decisions typically with respect to post-surgical adjuvant therapy, receives chemotherapy or radiation therapy after the hysterectomy. So we do assess that, and we've been asked in our province to distinction between focal lymphovascular invasion, 3 or fewer, or greater than 3 spaces with tumor in it. So this would be extensive, has multiple identifiable tumor emboli just in this one section. And you don't have to have a deeply invasive tumor, so you can have a stage 1A tumor, tip high grade, but the presence of high grade and LVI, even for a stage 1A, in our center would drive the decision to offer adjuvant therapy. Staging. We don't anticipate any new in the staging world. Regional lymph nodes. Places are starting to see sentinel lymph nodes, and the most recent amendment to the CAP checklist added isolated tumor cells. We have no idea what it means, so we just document it at this point, coded as N0I+. Additional pathological findings that changed to reflect the new 2014 terminology, where we no longer have simple or complex as modifiers of hyperplasia, and EIN and atypical hyperplasia are considered synonymous. Studies, you might look at the lower uterus segment to see if it's cervical type, P16 versus bimetric ER. We increasingly are asked to look at hormone receptor expression in tumors, and then there's DNA mismatch repair. 35-year-old abnormal vaginal bleeding, endometrial cancer. And at our center, we look at all endometrial cancers and all ovarian endometrioid or clear cell carcinomas for mismatch repair expression. You only have to do MSH2, PMS2, but we're doing the whole 4-marker panel at this point. Otherwise, you would end up back and staying for an additional marker in those cases that are positive. Actually, positive is the wrong word, that show abnormal mismatch repair expression. And that would guide testing at the Hereditary Cancer Program. BRAF not used to sort out hereditary versus not hereditary in the endometrium the way it is in colon. So we just stop at this 4-marker panel, and then we use a canned comment in the report. This is what you're looking for. So expression, loss of expression, those are just lymphocytes that are expressing here for MSH6. And these are canned comments. Hopefully we'll get some standardized terminology here. It can be confusing for clinicians in terms of how to interpret reports if we use irregular wording to sign things out. So within our center, we use these as the standard, these examples of the standard terminology that we have available in our system. And there is a push on. This is a recent paper from last year. We can screening everybody with endometrial cancer for mismatch repair abnormalities. Pick out Lynch syndrome. It affects their management, affects screening for colorectal cancer because endometrial cancer is often the index, very first present cancer in those patients. And these have, on average, 3 or 4 first-degree relatives who are eligible then for testing, for whom surveillance can be instituted. So it has implications, and the CIQC Diagnostic Immunochemistry Symposium this year is on hereditary cancer syndromes, emphasizing how to get started in the business of mismatch repair testing. People do it different ways. Some people use the morphology, whether it's uterine segment, whether there's tumor infiltrating lymphocytes, they use age. We are just doing everybody reflexively. And the first slide for endometrial cancer is to highlight this group where they have histological diagnoses. Type 1, low-grade endometrioid. Type 2, serous, easy diagnoses. A lot of cases that we have trouble typing. And bringing forward Cancer Genome Atlas, or TCGA, where they found 4 groups based on the genetics. And those 4 groups here with polymerase E mutations, those with satellite instability, so ultra-mutated, hypermutated, and then the ones with low copy number and high copy number variation. What we're finding is that more weird-looking endometrial cancers fall within these two groups, the repair deficient ones, where they have either satellite unstable or poly mutations. And these account for a third of cases, and that if we diagnose those proactively, I think a lot of the problems with observed variation are going to melt away. What's left after that's gone are the endometrioids here and the high-grade serous here. Turns out that the copy number high group P53 is an excellent surrogate. So if I just do a mismatch repair immunostaining, P53 immunostaining, we can reproduce all of this classifier except this one here, which is less than 10% of cases have poly mutations, and we don't have a good surrogate for clinical use at this point. So at the end of the endometrial portion, I'm pretty much at the end of my time. I just move quickly to the assignment for tubal ovarian cancer, because that is going to be a dramatic change from the way we've been doing things all along. Primary site assignment, high serous carcinomas of tube ovary. And just forward, the historical perspective on site assignment was you basically defaulted to calling them ovarian. And that's not the way it will be moving forward. So this is reflect what is an ICCR, which was just accepted for publication in Modern Pathology this morning. The ICCR guidelines use this same system we're going to talk about, and CAP is poised to accept them as well. So we knew in hereditary cases, we were surprised to find that tubal epithelial abnormalities were actually common than ovarian early cancers. When we started looking for serous tubal intraepithelial carcinoma, we found it not just in the cases, but the sporadic cases. Tubal involvement usually unilateral. In contrast, the ovarian involvement usually bilateral. This is more in keeping with metastases. And I think what changes it is that just as in early cases of hereditary high serous cancer picked up and producing salpingo-oophorectomy specimen where the vast majority arise in the fallopian tube. When we look at early sporadic high-grade serous cancers, these incidental tumors detected at the time of hysterectomy, say for prolapse, not common, but we have cases, and when they're confined to one site, it was the fallopian tube in every case. So some were more advanced stage, even though they were incidental, they were stage 3. But if you look at true organ-confined tumors, all of these end up being fallopian tube. So it's very clear that the sporadic cases and the hereditary cases are the same. When they go on to develop progressed advanced stage disease, the dominant mass is adnexal, but it's fairly compelling evidence they've arisen in the fallopian tube. WHO Blue Book came out, and the decision made to be rather ambiguous about site assignment. You must assign site, but no direction given. Intense issue at that time. The lines are easy to apply, are reproducible. This has been studied. They reflect our current understanding, which is that fallopian tube is the primary site in most cases, and they can be applied in patients treated with neoadjuvant chemotherapy. So this is a description of the original proposal. It's now been validated. It's in pathology, and this is from the ICCR guidelines that are coming out in Modern Pathology now in press. So ovarian mass, if they're thick, it's of primary fallopian tube carcinoma. Ovarian mass and the fimbria of the fallopian tube is owned by the mass, fallopian tube carcinoma. If there's no adnexal mass, if there's a stick or mucosal invasive carcinoma in the fallopian tube, it's still a fallopian tube carcinoma for classification purposes. So the exceptions to fallopian tube carcinoma are the patients who have an ovarian mass, no stick, or a peritoneal mass without an ovarian mass and without mucosal involvement, and the rest end up being called primary fallopian tube carcinomas. So adopted by CCR and soon to be adopted by CAP in the new checklist, which will come out this year. So we put this to a large prospective, and what you end up doing is most cases, over 80%, end up being called tubal. There's some where you don't find anything in the fallopian tube. The way you see anything in the fallopian tube is if you serial section the tube and submit the fimbria in toto by the CFIM, whether you need to put the rest of the fallopian tube, the isthmus and ampulla, but all of them occur fimbrial end. Some do occur in this part of the tube. So you don't see the whole tube this way, you will miss small tubal mucosal lesions. It's not unlike high-grade serous cancer and endometrial polyps. It can be associated with red even in the absence of invasion into myometrium. Here's it's exactly the same phenomenon here. These cells are predisposed to detach, float around, and reimplant elsewhere, particularly on the ovarian surface. And no implications for treatment. Huge implications, though, for prevention and screening. Screening is based on found to pick up an adnexal mass, by definition, picking up advanced stage disease. We'll wonder that we haven't seen any benefit from screening. No, may be possible, and this is the opportunistic salpingectomy opportunity, where the tubes are taken out at the time of gynecological surgery that is indicated for other reasons. For example, hysterectomy, take the fallopian tubes, or tubal ligation, take the fallopian tubes. Fallopian tubes do not need to be submitted according to risk-reducing protocols in that scenario. It's a preventive measure, and the yield in terms of picking up any pathology is very, very, very low, but routinely we would look at the fimbrial ends of those tubes. I suspect you're already seeing those types of specimens, and you may even have had encountered occasional cases with pathology, but usually not. We go through hundreds of such cases without seeing anything, and you have the benefit of maintaining ovarian function in these young women. It's quite a dramatic change in the practice at our center, and the statistics would suggest that it's happening across Canada. So thank you very much. I'd like to acknowledge Dr. Mary Kinlock's help in putting this together, pathologist from Saskatoon, who's with us here at Vancouver General Hospital. And now open questions.
Thanks so much, Dr. Gilks. We will be feeding you the questions from our end. And just a reminder to participants, you can submit your question using the chat feature, which is found at the top right-hand portion of your screen. We do have a few questions that have come in already, so I'll get started with those. The first is from Raymond Monk. Institution is not known, but the question is, if you do not see the fimbriated end in salpingectomies, do you indicate a report that should be included in future salpingectomies?
Don't make recommendations around full salpingectomy in our reports. So our colleagues, our surgical colleagues, have taken the lead on this. They're the ones who are dealing with their peers, the surgeons. Some people there's been good uptake in some centers, not so much in others. Unlike the hereditary cancer guidance, which we very specifically give, we do not feel at this point we're in a position to recommendations and path reports around practice with regard to opportunistic salpingectomy. To show that it increases mortality is circumstantial evidence where people have looked at patients who've had salpingectomies in the past and seen lower cancer incidence. But to actually see a prospectively, we're collecting data and we'll see if there's the expected decrease in number of cancer cases and deaths, but that data is not in yet.
Okay, great. Next question comes from Brampton Civic Hospital from Amir. The question is, WHO does not recognize complex or simple endometrial hyperplasia. Instead uses hyperplasia with or without atypia. It is understandable by clinicians.
Well, my way of handling changes in terminology at the WHO level is to go for about a year where I comment and say that in keeping with the new WHO of preneoplastic lesions of endometrium, atypical hyperplasia is not further classified based on the architectural findings as full or complex, and just keep sort of pounding on it that way. I think if you put it out in a report without a comment, any new terminology is going to generate phone calls. So, but I think you head them off, and when you have as robust a reference as the WHO Blue Book, it's pretty easy to say, oh, this is what people around the world are doing, and we have switched over. But I give it about a year, honestly, for this to become familiar enough to my clinical colleagues that I don't have to specifically comment on a change in what I've done over the last 20-odd years to something new.
Thank you. There's a second part to that question, and the question is, WHO does not use size criteria for EIN. Do you agree with that?
This is kind of a funny one. So there are size criteria for the old atypical hyperplasia versus carcinoma. It had to be a low power field. It was a Kerman and Norris paper, and this is how me in the mid-'80s at the Armed Forces Institute of Pathology saying, well, Dr. Norris, this can't be a cancer because it doesn't meet the size criterion. And his response was, I don't care what the size criterion are. I'm going to call it cancer. EIN thing is my experience has been sort of the same. We use them as a research tool to make sure we're talking about real pathology, but if you come up with something that's atypical and does not meet the criterion, experienced people still going to call it atypical hyperplasia or EIN. So I think that was a pragmatic reflection of the talk around the table. I was in the other room at the ovarian, so I'm just conjecturing, but that's my take on discussion with people after the fact around size criterion, that we use it for uniformity to study natural history, but it tends to erode in practice, and that if you have something that is sort of a good going atypical hyperplasia or EIN, even if it doesn't quite make the arbitrary size criterion, people are going to call it as such in practice and not ignore it or bury a comment. So I'd pick up, but that's what they did, entirely consistent with what I'd seen over the previous almost 30 years of people having these criteria in papers and then ignoring them in practice.
Thanks. The next question is from Dae-Tung Kim, and the question is, what is your opinion in morcellation procedure for these tumors?
Well, you desperately hope not to get a cancer in a morcellated specimen. That very fortunate case of the, I guess, anesthesiologist in the Harvard system who had a leiomyosarcoma that was morcellated, has garnered a great deal of attention in the American press and in the sarcoma world. We don't get them because we're a cancer center. I don't know what folks are up against in the centers that are done more routine. I can certainly imagine the advantages for the patients of having this, and if you've had your body to exclude carcinoma, they've been doing for years without problem, but it would be a acknowledged, whoops, that shouldn't have happened scenario if you had a carcinoma in a morcellated specimen. That would not be standard of care to morcellate it knowing that there is a tumor there.
Thank you. The next question comes from Grand River Hospital and Dr. Bashara. The question is, do you use only nuclear grade 3 to upgrade endometrial cancer? How about cancers showing granular architecture and nuclear grade 2?
I use the notable nuclear atypia, so 10x. Wow, yeah, that's atypical degree of atypia grade. So I don't use subtler degrees of atypia within that spectrum. Now, nuclear atypia is the least reproducible of our structured grading system criteria. So we're up against it. What Rich means by notable nuclear atypia, we can only guess, but what we're seeing is that it co-varies with some of these molecular markers, and I'm optimistic these days about having surrogates for notable nuclear atypia in these gland-forming tumors that have higher grade cytological features, and we all see them, and we all struggle with what to call them. And I would venture to say that a significant number get called mixed on the that. Well, I can't really go wrong if I call it mixed serous and endometrioid. I covered all the bases. But those are the ones that I think show up in POLE or mismatch repair abnormality group, which is a full third of our endometrial cancers. And I'm hopeful that if you pull out those two groups, one has an extraordinarily good prognosis despite high stage or high grade nuclei, or in some cases advanced stage disease. That's the POLE group. And the other of which is sort of an intermediate prognosis, the mismatch repair. And we know from colon cancer they can be more advanced stage and still get a good response to therapy. That the P50 abnormal, for example, may be the surrogate we're looking for in terms of being a surrogate for grading based on straight morphology criteria, the one that would place it into a higher risk group where the therapy is warranted. So a very circuitous answer, basically saying, no, I look for nuclear atypia visible at X before I would upgrade on that basis.
Thank you. This question comes from Shahid Islam, and the question is, how would you stage endometrial cancer in a cervical polyp?
Good one. I think I've ever encountered that. I've seen things called cervical polyp that were just polyp endometrial cancer, and you assess stromal invasion the same way you would otherwise. So, the answer to that one, sorry, it must be an uncommon circumstance to have a usual benign endocervical polyp involved, or even to find one involved by ends pretty common, but to see it involved by endometrial cancer must be really rare. So sorry, I think it's one that comment. It's one of those cases that we can't place the patient's tumor in the context of hundreds or thousands of similar tumors. It's sort of a one-off. I would have knowledge in my report that I was uncertain about the staging in a case where there's cervical involvement but confined to a cervical polyp.
Thank you. The next question comes from Henrik Rees, and the question is, does the CAP protocol recommend using the SEFIM protocol in all cases where axial, peritoneal, ovarian carcinoma is suspected?
So we don't have a draft yet, but except the ICCR, it will be that you submit the fimbria in toto by sectioning along its length to maximize the area exposed. There's an interesting experience from an audit that was done at the Royal London Hospital where people were supposed to be doing that, and then they looked back and they weren't. And when they switched over and actually did what they were supposed to be doing by policy, significant increase in the number of cases where you see tubal mucosal involvement and sticks. So it does influence site assignment. Is it worth doing given that it does not influence treatment? Well, there's a lot of cassettes to put the fimbria. I see the argument against doing it. You're going to treat them the same way anyways. But if you don't put those extra sections through, you will end up calling things ovarian where there is unilateral tubal mucosal disease.
Thank you. This is a repeat, but the next question is from Roz Circa, and the question is, for which tubes do you see or do you use the SEEIM protocol?
We put the whole SEEFIM through all risk-reducing single oophorectomies or salpingectomies. Patients with either a family history of ovarian or breast cancer, or personal history of breast cancer, a known BRCA mutation. We put the whole thing through. People with an adnexal mass, we put the fimbria through by that same protocol, but we don't put the whole isthmus through. And to have opportunistic salpingectomies, again, just sample the fimbrial end of the fallopian tube, one cassette. Unless you see something, of course. This was out of an audit of hundreds of cases where we put the whole through, and the only abnormalities were seen in patients who had cancer in the adnexa, like the high serous cancer patients, and all the other ones where it was done for prolapsed uterus or iomyomas. We didn't see anything, so we stopped doing it at that point. Those cases.
Okay, thank you. The next question is from Nick Van Westhuizen, and this is maybe looking for your comments, asking for an addition to the CAP protocol. So I'm not sure what you'll be able to provide, but the question is for endometrial carcinoma regarding the involvement of cervix section in the synoptic report. Can involvement of cervical epithelium only be added to the CAP checklist?
Yes, it should definitely be added. That's a weird oversight in the current checklist.
Okay.
If you have the option of add it provincially, which we do, it's on our list of changes for the BC checklist. We just make some minor adjustments to the endometrial protocol for local use. We've gone ahead and added uterine segment as a site, for example, because we have the ability of intuitive to make those changes. So that should be forthcoming for BC.
Okay, great. From our side as well, I think we can take initiative and send that off to CAP as well, and to them. It can be included. Well,
I have the list of things we submitted. I don't see it here, but you're right. I mean, it definitely should be. It's on a list to do in BC.
Oh, okay, great.
It may not have been on our expert review panel submissions that I'm just quickly looking at here. So we can still submit to CAP on that one.
Great. Question comes again from Shad Islam, and the question is, how do you measure the depth of invasion of endometrial cancer when it involves adenomyosis?
Oh, guess. Just take a guess, really. You have to decide whether the invasive focus is coming off the adenomyosis or whether the invasive cancer is overgrowing the adenomyosis and coming off the surface. And the conventional sort of thing is to leave it at that, knowing that it really hasn't answered your question. And the reason is that there's not a good answer to your question. We don't have robust criteria that when you look down the slide will help you. They're just words, and they fail in a significant number of cases. So those are the ones we show at conference, and we document the interdepartmental consultation. We do our best in terms of guessing with respect to the single most important aspect of the question, which is it inner half or outer half? And that's what you're left having to guess with. And those are your choices. Inner half greater than or equal to 50%, and in the comment document, difficult to measure because of the presence of extensive adenomyosis. You're it's one of those ones that we show regularly to each other here, and you probably would do this. It doesn't necessarily make you smarter or more frequently correct, but it helps you sleep at night.
Great. Okay, the next question comes from McMaster University in Ontario. The question is, in subtyping endometrial carcinoma, do you use the terminology of ambiguous morphology, and what is your criteria?
I don't use ambiguous except in talking to other pathologists, where it's a really useful term, because once you use it, especially around the multi-headed microscope, people know exactly what you mean. And you talk about things that we look at up and down the hall. This is one of the big ones. Do you think this has a serous component? Do you think this is a serous cancer? And historically, we've done it straight HE. We did a study where we looked at correlations with genotype, and the reckoning that came out of that was that you have an ambiguous morphology, which is to say villodular, papillary, glandular combination, highish grade nuclei, but not really high grade like a usual serous, maybe not as much tufting as a real serous. Ambiguous. What do you do with that? And it's such an important distinction. Do you call it endometrioid grade 1 or 2, or do you call it serous grade 3? So P53 seems to be a useful discriminator, and it happens to be the same recommendation that Rob Soslow made when he was describing these ambiguous tumors. So coming at completely different approaches, one from more of a genomics approach, his from more morphological. Same solution, a simple solution. I have this tumor, I'm having trouble, I will do P53. We don't do a lot of P53 for endometrial cancer. Mostly we can sort it, but I how we're handling them. Also struck, now that we're starting to look at poly mutations, that I think most of our ambiguous cases are going to be not usual serous nor usual endometrioid. They're going to be associated with these DNA repair defects that the TCGA has pointed out. And if we take those out of the mix, I have a feeling what we're left with will be relatively straightforward. It'll be serous or endometrioid. And we won't struggle the way we do now so often, I think. And we had Phil Clement and I had one yesterday, and we've been doing this for decades, where we still struggle with these tumors that, well, it's higher grade than usual endometrioid, but not that high grade. This one had a lot of tumor-infiltrating lymphocytes. It really did look like it could be one of these polys, but at this point it's still a morphological assessment. We do use P53 for the ambiguous tumors of the sort that Soslow described.
Next question is from Dr. Mark Rickenberg from Ontario. And the question is, what is the role of IHC for WT1 in working at metastatic serous carcinoma?
I do not do WT1 for serous cancer, say in an omental biopsy, because we never validated it as a marker of exurine versus endometrial. Glenn McLeod does. They have validated their WT1 staining, and as they do WT1, it shows it's much more likely to be expressed in the extrauterine cases. So we don't have the data for our staining for me to be comfortable. This time it was high-grade serous carcinoma, and we'll have to clinically sort out whether it could be coming from the endometrium or not. Again, it's not a big difference in terms of going ahead with neoadjuvant therapy. The clinicians are happy enough with that response. We're in the process of doing the study to look at WT1 as a way of distinguishing between endometrium serous versus ovarian serous. And at that point, we may do what Glenn McLeod does. Just a comment about WT1 staining. Run 2 CIQC. The WT1 staining across the country is pretty brilliant. Really good. P53 not quite so good. Actually, P53 is sort of awful. But the napsin and WT1 was very, very good. So if any of us can get there showing that WT1 can be used, how good it is, sensitivity and specificity in terms of distinction between and versus extrauterine primary site, then probably the rest of the country can follow that, because our staining across the country was really brilliant. We haven't put out our report yet on that run, but it was really good.
Thank you. The next question comes from Amir Samani. And the question is, do you believe that very complex architecture without nuclear atypia is EIN?
The short answer, yes.
Great, thank you. Next question, Dr. Racy. The question is, endometrial carcinoma, do you always submit both ovaries and fallopian tubes in toto, irrespective of their sizes?
No. Coming much more clipped in my responses here, you'll notice.
Well,
How many questions do we have?
We do have a few more, so we'll try to get through. I think there's 3 more that I have now.
Sure.
We'll try to get through those. Dr. Yee asks, what is a management protocol for incidental STIC findings?
The amount of incidental serous intraepithelial carcinoma at the center is and it right now constitutes staging. Staging is negative ovulation. 2 stages, small numbers of cases, good outcomes. We were learned early in cases where we had incidental tuberosal disease, and then back 2 years later with high-grade serous cancer. But they were not adequately staged. And if we look at these patients from the pub series, there's one from Memorial, I forget the other ones from, it's something like if you're sure they haven't spread, then you observe them. Interestingly, of the incidental high-grade serous cancers, our cases, just over 20 cases, had already spread, so they were not organ-confined. We're in the process of getting follow-up on those cases, and hopefully that will bolster our confidence in our current approach. No one has enough data to be really comfortable in talking to patients around, this is definitely the way to go, but we've moved away from the early days when we might have been more likely to give chemotherapy to trying to ascertain whether there's ovarian or mental disease. If there is, obviously they go on for chemotherapy. If there's not, they stop there.
Thank you. This question is, how do you assign primary site with occurrence of tubal, STIC, and endometrial serous cancer?
Well, darn good question. We actually have a study ongoing to look at this. I suspect most of those are missed from the endometrium tubes, and even not uncommonly with high-grade serous endometrium, where there's tubal disease as well as extratubal spread and ovarian disease. Glazer's has agreed to do the WT1 staining since his staining is validated. The first cases we've looked at have been endometrial. It's surprising that when tumor gets onto the mucosa of the fallopian tube, it can mimic a primary. Joe Raban had a very nice paper on this. They can even be non-gynecological tumors, like a transitional cell of the bladder, and it can look like a stick. But hopefully we'll come up with data that says, if it's WT1 negative, watch out, it could be from endometrium. So my sense of this in rather data light era of February 2015 is that these are endometrial high-grade serous cancers showing tubal spread en route to becoming advanced stage serous cancers of endometrium.
I have two more questions, so we'll try to get through them both. The first is from McMaster. Ones with ambiguous morphology, after using P53, which does not show staining consistent with serous, do you call these endometrioid cancer and upgrade them by 1 grade?
Typically call them a grade 2 endometrioid. The ones I have in mind are not very solid. They're architecturally low, but cytologically not like a low-grade endometrioid, so they end up going out as a low-grade endometrioid.
Thank you. And we've made it to the end of the list. So the last question that we've had come in is, what criteria do you use to distinguish between mucinous carcinoma of the endometrium and benign mimics?
Everybody struggles with that one. And those are the ones we sign out on a sampling of the endometrium, a curating or biopsy is mucus endometrial proliferation, please see comment, and we each other and hold hands and hope for the best. Ultimately in the hysterectomy, the architectural features, because we don't handle on any cytological features that are helpful, that distinction, and that we have fairly low threshold for mucinous endometrial proliferations in terms of to the plastic category, saying we cannot exclude a low-grade mucinous carcinoma, a low-grade endometrial carcinoma with mucinous differentiation. They remain a huge problem. Fortunately, not that common.
Thanks, Dr. Gilks. That puts a close to our question and answer period, and I'll hand it over to Dr. Shrigley to close us out.
Thank you. On behalf of Cancer Care Ontario, the partnership, and the Canadian Association of Pathologists, I'd like to thank Blake for this very comprehensive, informative, and clear presentation today. This is the fourth session of the 2015 series of CAP checklist presentations, and we would welcome your comments and suggestions for ways to ensure that these sessions are informative and relevant to your practice. Please include your feedback and suggestions as part of the completed online evaluations. Once WebEx recording of this presentation becomes available, it will be made widely available through links with Cancer Care Ontario, CPAC, and the Canadian Association of Pathologists. Access to this recording will be available for review at your convenience that is not restricted. As a reminder, both the live and recorded presentations are eligible for CME credits. Please see session notice for more information. The sessions will remain available electronically for an undetermined period of time, but the CME certificates will only be issued for 1 month following the presentation. Please refer to the session notice for the exact date. Please note that the next session that we're going to have is going to be, we're going to be departing actually from the actual checklist framework, and David Drummond of University of Western Ontario will give us a update on colorectal polyps. That session is at the usual time, but on March the 11th, a couple weeks now. So look forward to seeing or hearing you on the next session of this series. Bye now.